Just give me a minute. Okay, I guess all of us would have experienced pain at some point of our lifetime, like, isn't it? And they say pain is really good because pain indicates the pathological changes in our body, and it is a warning sign to identify the most severe symptom or whatever it is. But if the pain is going to persist for a very long time, it's going to cause it's going to cause emotional and also psychological, whatever it is, physical, or it's going to interrupt the whole process of our life. It might change the quality of our life. So my topic is going to be on pain and coping strategies among patients with PAOD. All of you might think, what is PAOD? It is called as peripheral arterial occlusive disease. I just thank all my guides and co-guides for helping me with this study. Going on to the study as such, what is peripheral arterial occlusive disease? Initially, it was thought it occurs only in the Western countries, but right now, it has become a global vascular problem. To be honest, especially in India, I would see previously when I was a student, probably an UG student, it was really the percentage of patients who had PAOD was very minimum. But right now, I could encounter minimum of 40 to 50 patients per day in the OPD just with PAOD and intermittent claudication. What is intermittent claudication? It's nothing but pain when they walk. It starts from mild to severe. Mild can be like it might occur very rarely, whereas severe, they can't even take one step forward. That is how severe it is, and it really influences the patient's life. Okay, though it is not life-threatening directly, but it plays a major role in the cardiovascular morbidity and mortality. When you go into this disease condition as such, if you go and browse through it, all of you can understand how important it is. And I'm just skipping all this. Okay, what is the need for the study? It was in a vascular screening program. It was estimated that every 20 Indians over the age of 15 has been diagnosed with PAOD, and it has affected 9 million population in our country. And right now, it actually substitutes or it includes 5-fold risk of cardiovascular events. It poses 2 to 3-fold greater risk of mortality with PAOD patients. And in the institution where I did this study, almost around 600 to 700 patients get admitted per year with this problem. Whereas, as I mentioned already, 25 to 30 people or 30 subjects or 30 patients came to the outpatient unit with the complaints of intermittent claudication. Okay. The objectives of my study was, first of all, to assess the level of pain. Next, to identify what kind of coping strategies are they adapting, whether they are adapting an active coping strategy or passive coping strategy. Next is to correlate the level of pain and the coping strategies. Next is to associate the pain with the socio-demographic variables. How is socio-demographic and clinical variables affecting or interacting with this pain, and to compare the coping strategies with socio-demographic and clinical variables. I'm just skipping off these hypotheses. Okay, how did I go about doing this study? Methodology, this is completely a quantitative study with a descriptive design. The setting was general surgical wards and the outpatient department of Christian Medical College, Vellore, India. Sampling, 75 subjects were chosen, and consecutive sampling was used for this study. The criteria or the inclusion criteria was patients who had PAOD for more than 3 months, patients who were above 18 years, who were able to read the languages, the local languages, especially the Tamil, Hindi, and the international one, the English, people who are willing to participate. The exclusion criteria was patients who had malignancy or major complications like stroke and previous amputation, cognitive impairment, who died or got discharged during my study. Data collection instrument, I used 3 data collection instruments. One is the socio-demographic and clinical profile. Next is the numerical pain rating scale and the pain coping inventory. Okay, under the socio-demographic profile, I had age, gender, marital status, occupational status, financial dependence, type of family, whether the nuclear joint or and location of residence, whether they are from urban or rural. Clinical profile consists of diagnosis, duration of illness, duration on treatment, comorbid illnesses, associated risk factors, pain medications, and previous surgical history. Numerical pain rating scale, already we know it's from 0 to 10, and the patient verbalizes. It's a subjective rating scale where the patient points out on which score will they want to give for their pain. Pain coping inventory. This was developed by Flores Kremath and Andrea Evers in 1996. This scale consists of two domains, major domains, that is the active coping dimension and passive coping. Active coping has three sub-dimensions, that is the pain transformation, distraction, and reducing demands. Passive coping has worrying and resting. Okay, this was the pain rating scale which I used, 0 to 10. It has been classified as mild, moderate, and severe. Pain coping inventories, as I told you already, there are 33 items in it on a 4-point Likert scale, and it's been classified into two dimensions. Okay, how did I go about doing the study? I had collected the information about the patients and given it to the MRD, that is the medical records officer, the previous day. And on the day when the patient arrives, they will meet the physician, and the patient will be directed to my room so that I will be taking the informed consent. I place all the self-administered questionnaire, and after that, I use the SPSS to get the inferential and descriptive statistics. Paper has been published already. All the pain level of pain and the coping strategies were analyzed by descriptive statistics and frequencies, whereas the relationship between level of pain and coping strategies was measured by Pearson's correlation coefficient. Association between the level of pain and variables were done by chi-square tests. Comparison of the coping strategies with the variables were done by ANOVA. Going on to the analysis and discussion. Okay, majority of my subjects who were diagnosed with PAOD were male, that is 88% of them. They were under the age group of 35 to 50, and the mean age group was found to be 52 years. And majority of them were married and had received a secondary level of education. 65% of them were employed, and around 57 hailed from nuclear family. Around 61% came from the rural area, whereas patients who had been diagnosed for less than 2 years contribute around 54.7%. 93.3% of them, that means the majority of them were on painkillers. Okay, going on to the distribution of subjects according to the associated risk factors. If you can see this bar chart, 76, that is the majority of them had the history of smoking, and half of them, 32% of them, had alcohol consumption, whereas the other risk factors were in a meager amount. But smoking had contributed mainly to this PAOD, and it is found that it is one of the major cause of peripheral arterial disease. Going to my first objective, level of pain, it has been found that 50%, almost 51% of my patients or subjects had severe pain, whereas 37 had moderate, and only 12% contributed to the mild pain. And the second objective, coping strategies in relation to pain among the patients. Most of them used passive coping strategies in order to overcome their pain, rather than choosing the active coping strategies. Active means the other name is adaptive coping, whereas passive is maladaptive coping. If you can find almost 80 people had adapted passive coping. And going on to the correlation of pain, level of pain and related coping strategies among patients with PAOD. If you can see the p-value over here, the p-value is less than 0.05%. So it means almost every patient or subject has adapted some sort of coping strategies, but most of them come under the passive coping. And when the pain increases, the active coping has reduced. This is the figure of it. When the pain score increases, the active coping strategies have decreased, whereas when the pain score increases, the passive coping has significantly increased. So most of my subjects have used only passive coping. Okay, as I already told, there is a weak negative correlation between level of pain and active coping, and there is a moderate positive correlation between level of pain and passive coping. Association of pain and coping strategies with selected variables. Okay, level of pain was associated, had a significant interaction between the risk factor of the family, sedentary lifestyle especially, and also with the intake of pain medication. There was a significant relationship between active coping strategy with residents, especially the rural area, and there was a significant relationship between passive coping strategy and intake of pain medication. Okay, implications of my study. For nursing practice, how would this study help? To be very honest, in my institution, this was the very first study about peripheral arterial occlusive disease, especially from nursing perspective. Going on to how it will help the nursing personnel is, when nursing personnel address the pain issue, they always address only about the pain. Okay, have this medication, but but the suggestion to the patients how to adapt to that pain or how to decrease that pain is not being dealt in detail. So that this study would definitely throw a limelight to the nursing personnel to also look into the coping strategies aspect in order to improve the quality of life. For the nursing education, definitely it would help the nurse administrators to provide CNEs, regular CNEs on pain management, and also to involve coping strategies and other aspects of pain management in it. And also for the nursing students to conduct clinical teaching sessions for the patients in the hospital setting. Whereas for the nursing research, PAOD can be taken as one important aspect, so that this specific disease condition might pose different areas of research in order to help the patients to have a better life or quality of life. Conclusion, most of my subjects were using passive coping strategies. So I had developed an educational intervention to give as a pamphlet to the patients in order to cope with the pain in a positive manner. Any queries, or if you want to ask me any questions, welcome. Thank you so much.
Thank you, ma'am. Dr. Renuga, Devi.